Hi, Ian. This is
Hi.
yeah. Hi. Before we start, do you mind telling us a little bit about yourself and maybe your career so far?
Okay, so I am an ancient jobbing physio. I qualified in 1989 at Withington Hospital School of Physiotherapy, which unfortunately now no longer exists. And did my 3 years there, and then went into the NHS when I qualified. But I was quite fortunate that in my second year, when I was at Withington, I got pushed by the hospital to go down and do some voluntary work with one of the senior rugby union clubs in the area, and so had to learn on my feet a little bit more about muskuloskeletal physiotherapy and especially rugby. So I worked in the NHS, then worked in private practice for a little bit, moved over to Yorkshire near home where I came from, and worked in private practice, and then carried on working for the local senior rugby team. And then through a bit of serendipity, I did a little bit of work for the old division of rugby, the North Division, and through that ended up working for England Students Rugby Union, and then that went on to be England A and England Sevens, and I was very lucky to be part of the support structure for the elite playing squad for the 2003 Rugby World Cup when England became Rugby World Championships. Then along my way, I did completed an MSc in sports injury and therapy at Manchester Metropolitan University, and then I completed my PhD at Salford University in 2013. Joined EIS, English Institute of Sport, in 2008 as a sort of cover physio, and I've been there the last 12 years now. I'm the upper limb technical lead nationally, and as I say, through being in the right place and having the right credentials, I've been to the 2010 and 2014 Commonwealth Games with England. I've been to the 2012 and 2016 Olympic Games with Team GB, and I should have been in Tokyo in July. So maybe be in Tokyo next July if we get there.
And I understand you specialize in shoulder pain and shoulder injuries. That's your kind of area of expertise.
Yes, again, through from my interest and my background in rugby, when I was working for England, there was the first injury audit that the rugby union did, showed that one of the top three injuries in rugby union was shoulder injuries. But the thing that sparked my interest more, that a high percentage of those shoulder injuries were recurrent shoulder injuries. So I started my PhD trying to find out why there was so many of the shoulder injuries in rugby were recurrent in nature, and so basically spent the last almost 20 years working in and around and studying and researching around shoulders. But in my day-to-day practice, I still work as a general musculoskeletal physio as well.
So thinking of all musculoskeletal problems, how common is the shoulder pain and shoulder injuries?
I mean, generally, if you look at sort of across Europe and things, it's about the second most common musculoskeletal injury that presents at sort of a GP practice. And some of the literature says that about 70% of people will experience shoulder pain in the lifetime. But again, a lot of that shoulder pain is either recurrent or it's chronic. And again, I just looked at some data before this, and it was saying about 1% of UK adults consult the GP regarding shoulder pain. And just for that initial consultation, that equates to about 310 million pounds per annum, which is a lot of money for one part of the body.
Yeah. So Ian, are there any universal exercises that people with shoulder pain can do?
I think, and again, anybody who's heard me speak and a lot of us speak about it is about just thinking of the shoulder's just part of your body, and it's one end of the kinetic chain. And I think one of the biggest things that people can do, so we're not thinking about sports people, they're just general people, is try and get good posture. So around the thoracic spine and chest, if we can get the optimal positioning of the scapula on the chest wall, if we've got a nice optimally flexible thoracic spine and rib cage, that will enable good mechanics around the shoulder, and is likely to reduce the incidence of non-traumatic shoulder pain.
What type of sport are you most likely to have shoulder problem or shoulder issue? Is it the rugby, or would you say the gym goers? The same
Yeah, I mean,
kind of...
it's changing a little bit. I mean, certainly in rugby, I've been involved in rugby for the best part of 30 years, and it's become more professional on the sports medicine and sports science side. So, like with most sports, we prepare players better. So it's probably not as, in fact, it's not as big of a problem within. If you look at the RFU, their injury audit from there, it's not in the shoulder itself. It's not in the top 10 injuries, but in sports like swimming, it's a big problem. But swimmers generally have shoulder pain most of the time. But what will happen within that continuum, there's just sometimes that pain will be greater and will interfere with training and competition. So swimmers generally always have some shoulder pain. Most overhead sports get a high degree of shoulder pain. So sort of tennis, badminton, a little bit. Within Europe, certainly handball has a high proportion of shoulder injuries as well, and obviously across the pond in North America, baseball. Again, their pitchers, their throwers generally have quite a high incidence of shoulder pain.
There's a lot of talk about back care and looking after your back. Is there anything that one can do in terms of preventing shoulder pain and making sure it doesn't, affect you?
I think that like if we look at most studies that are looking at any injury and injury prevention programs, and it's sort of becoming increasingly more evidence, is that it's very there isn't a specific marker you can use to prevent any injury really from there, and it's a combination of factors. So the difference between an association and causality, people get mixed up with that. So it's a combination of factors that can lead to one person having a shoulder pain and one person not having a shoulder pain. But if I had to select some things that are easily manageable, it would be, when we're thinking from a sporting perspective and we think about the kinetic chain, that distribution of force that comes out of the upper limb and the shoulder, 50% of that comes from the waist down, 30% of that force is generated around the trunk, and only 20% generated through the shoulder girdle. So it'd be, from a sporting perspective, make sure you've got your 50 and your 30 as well as your 20 around your shoulder. Then I would say, again, something that I'm really, really passionate about in both the sporting and the non-sporting situation is that in the resting position, you need an upwardly rotated scapula. And the best way to sort of describe that is if you look at the scapula from behind and you find the superior angle of the scapula, so the top corner near the spine, and the inferior angle of the scapula at bottom middle. The distance between the inferior angle of the scapula and the thoracic spine, if you measure that, should be greater than that between the superior angle of the scapula and the thoracic spine. Because again, I believe that, again, from a biomechanics point of view, that will optimize the length tension relationship of the rotator cuff and reduce the load on the cuff. Also, biomechanically, it takes some of the strain off the capsule from just sort of maintaining the head, humeral head in the right position. So that's one thing that's manageable in all aspects of life. And then the other thing will be make sure that we get good balance. Our force couples around the shoulder, so the anterior cuff and the posterior cuff, the superior and inferior cuff, and then the balance between the scapular thoracic muscles and the rotator cuff muscles. If we haven't got a stable scapula, then that will compromise the output of the rotator cuff. So bit of a fan of the scapula, but amongst some other things that are important.
Patients very often ask me, how long does it take to recover from the shoulder injury or shoulder pain? That's the most common question I get asked. And what do you say to patients? Obviously, it must vary, but what type of answer would you give to someone like that?
Okay, so my answer to that to all my patients is it will take as long as it takes. So again, because we've got to know that there's lots of different things that can cause shoulder pain, that there's different conditions, whether we've got a biomechanical problem where we're getting some physical trauma to the cuff. So if we're getting an impingement mechanism for getting pain as we go overhead, okay, that unless you can sort out the biomechanics, then you're never going to get rid of the pain from there. If tissues have a time that it takes to heal fully, so we've got to consider the pathology and which tissue it is to get right, and then comorbidities, other things that are going on with the patient. Age is not a massive. Doesn't have a massive effect on there, but it does affect a little bit in it's fractionally slower. Tissues generally not quite as good condition as somebody younger. But what is important is about getting people to move, as Joe Elphiston says, beautiful and effortlessly. We want to make sure that a movement, and generally with our shoulders, it involves going up above our head. That it does look effortless. So when somebody does take their arms up above their head, it should be pain-free, definitely. But it should look like it's almost floating up. And if they're having to fight their arms up above their head, then that's indicative that we've not got optimal motor control for several reasons around there that we need to look into it from there. And it's about training quality movement from the get-go. And yes, we want pain-free motion, but again, we want to make sure that the biomechanics are optimal, or else we're just setting our patients up to come back again with an injury later on.
I've come to an end of my list of questions, Ian.
Right. Okay.
But if you don't mind, I've got two more questions. Okay. Shall we?
That's fine. Yeah, that's fine by me. Yeah.
So what's the most common shoulder injury or shoulder problem that you see in your clinic? What type of problem you see? Is it to do with tendons in the shoulder, tendinopathies?
Yeah, I think the tendon injury around down the shoulder that's related to the mechanism of impingement. Again, one of the things that a lot of my colleagues know that I say about a lot, that impingement is not a diagnosis at the shoulder, it's a mechanism. Okay, that's what it is. The mechanism of the pain at the shoulder is that some tissue, some subacromial tissues getting compressed and irritated, and that's what's causing the pain. So getting away from saying impingement as a diagnosis, it's a mechanism. So that faulty mechanism and that faulty mechanism can have three different components. It can be that we've got a scapular instability, that as we go up into elevation, the scapula needs to upwardly rotate 60 degrees. So we're looking for the inferior angle of the scapula to come to about the mid-axillary line to maintain the distance between the acromion and the humeral head. So that acromial humeral space. That's one bit that could be responsible for causing that biomechanical impingement. The other thing could be humeral instability, so the humeral head not staying centered within the glenoid, and that could be superior glide, anterior, posterior, inferior glide. So again, reducing that space between the humeral head and the acromion, and finally the contents of that subacromial space could be bigger than they should be. So again, if we irritate the bursa and the bursa swells, that's going to occupy a lot more of the space. Okay, loading a tendon makes the tendon bigger, and there's some good work done by Karen McCreesh showing the difference between a healthy tendon when you load it and a tendinopathic tendon when you load it, by the amount of increase in thickness of the tendon and the amount of time it takes for that thickness to return to normal. So looking around those, so there's three areas to look at if somebody comes with pain going into elevation, typical pain plaque, and it looks like you're getting mechanical impingement. So overall, I would say that is the most commonly presenting non-sporting type of shoulder injury that I see in my clinic.
Your approach is very much hands-on, isn't it? It's manual.
Yeah.
And what do you think about hands-off approach to rehab? And because there are lots of critics of hands-on.
Yeah, there's if you look at the history, certainly the Chartered Society of Physiotherapy in this country, it evolved from the Society of Masseurs. From there, our speciality is definitely a hands-on, and we know that the influence of touch, as soon as you lay your hands on somebody, you're going to influence their movements, their feelings, their move. And what you call manual therapy, if you think your traditional Maitland stuff, that is manual therapy. Massage is manual therapy. But again, just cueing people, touching people, giving them a proprioceptive input. Okay, again, will change how people move. So I am definitely not a fan of hands off. And I am a fan of hands-on, and there's a myriad of ways that we can have hands-on, and it's not all about doing sort of Maitland mobilizations. Even though I am a member of the MACP, I do use those, but I do use other techniques as well. Even just rubbing the skin over a joint to try and enhance its proprioceptive feedback. I think it's very, very important hands-on.
Thank you very much, Ian. We've come to an end of our interview, and
okay.
Thank you for your time. And,
good. I hope I spoke some sense, because it doesn't take a lot to get me talking a lot about shoulders. Quite passionate about them, as I am about the profession.
It's all very interesting. Thank you very much for your time, and all the best for the future.
Okay, thank you very much for the opportunity. Have a good evening. All right, cheers then. Bye-bye.